So I'm Hanley. I'm a pediatrician in town. When we first got the assignment to do this talk, and I don't know if you guys saw the title of the talk, I think it's What is an Emergency? And we both thought, I don't know. There are a lot of emergencies out there. So we tried to kind of take an approach that looks at some common illnesses that may or may not be emergencies to help give you guys a little bit of a framework to talk about how to make that decision about whether to go to the emergency department. So we're going to talk about 6 common things. If you guys have questions that come up, shout them out. We would love to answer questions. We are by no means omniscient, but we can do our best to try to answer them. So the topics that we're going to review are vomiting, diarrhea, and fever, chest pain, that's a big one, concussion and traumatic brain injury, wounds and wound care, pediatric ingestions, and opiate medications, kind of from a broad perspective. We're also, if we have time, going to try to do a little bit of practice, hands-on stuff. I don't know if you can see our arts and crafts table over there, and our half person down on the floor. So
there's a potato.
Yeah. Mark might take a bite out of it in the middle of the lecture. So we're going to try to do some hands-on time if there's time when we're done talking.
So I'm Mark Simon. Again, it's great to be here to talk to you about some things that we see every day. Dr. Hanley is not only a fantastic pediatrician and heck of a nice woman, but she also just found a tooth on the floor. So if anyone lost a tooth as you were walking in, she found it, and we'll take the thank you gift from you. So our goals for tonight, we've got several of them. One, we know that what you guys are really interested in health, right? So in the ideal world, we would all have 100% health and zero need for health care. But unfortunately, that world doesn't exist. And so our attempt here is to try to encourage you, give you information that may allow you to have more health and maybe less health care. And at the same time, maybe when you do need health care, make you feel a little bit more confident in the manner in which you choose to get that health care. We hope to answer some questions about some health problems. We'll probably also not answer some questions and maybe even raise some additional questions. We'll give you some things to consider as you try to make healthy choices. One of, again, the take-home points is that you have more control over your health in a lot of ways than the doctors and nurses and PAs and nurse practitioners that you see. One of the benefits of or one of the costs of being in a society that has affluence is there's lots of opportunities for us to do things that make our health a little more imperfect. And in the big scheme, we want to potentially help you guys save a life, maybe your own, maybe someone else's, and we'll try to give you some information to do that.
So we also thought we should talk about what this is not. So it's definitely not any sort of ploy to make money. I think the ER is plenty busy, so we want to empower you guys to make your own decisions. We're not saying come to the ER all the time. This is kind of a term that I think has been in the news a lot recently, but we don't have any conflicts of interest other than the fact that this is our field. We work in medicine. We hope emoluments don't come up tonight. I don't think we have any emoluments, if that's a thing you can have. And it's not comprehensive medical advice or kind of an overarching view of all of medicine. We're gonna touch on some basic topics, and again, we can answer some questions. So I learned by looking at cases and real life things. So I've tried to put together some case-based learning slides. First question, does anybody know who that is? Yes, a couple people know. It's Justin Bieber when he was 13 years old. But in this case, he's your 13-year-old son who came home from a sleepover kind of feeling okay, but then within a little bit of time of getting home, he started feeling like, I feel a little queasy. He has some vomiting and some diarrhea. I think I said vomiting 6 times, diarrhea 3 times, and a temperature of 104.1. So, is this an emergency? Yeah? Why is it an emergency? The fever? Okay. And the concern about dehydration? Okay, so those are great thoughts, and I agree. So the big concern is dehydration, right? So if somebody is vomiting and having diarrhea, from a medical perspective, I don't really care as long as they're able to maintain their hydration. I care because they're uncomfortable. I care because it's not pleasant to be running to the toilet all the time. But from a medical perspective, in terms of the physiology of your body continuing to work, when we get worried is when we worry about dehydration. So I think that's something that we're all going to have some sort of a GI illness in our lives, probably many, many times. So the thing that we as docs get worried about is, are you dehydrated or are you hydrated? So if we get concerned about being dehydrated, we can do some things about that, like giving IV fluids. So warning signs about dehydration. So if you throw up once, you're probably not dehydrated. But if you're having repeated episodes of vomiting and diarrhea, you could be approaching dehydration. So decreased urine output, so that's not peeing as much as you normally pee. I see a lot of babies, and I have to say in kids who have diapers on, it's really hard if they have a lot of diarrhea because you don't know, is it diarrhea or pee or what? So really, if you're concerned and you don't really know, it's always okay to ask the question and either come to the ER or call your doctor to get a better sense. A dry mouth, and I'm not talking about the dry mouth that we have right now, the like nervous dry mouth or the talking too much, but the kind of tacky mucous membranes where you don't see as much saliva. Not crying, again, that applies mostly to kids, but adults cry sometimes too, I hear. And then tenting of the skin. This is kind of a late sign, so if you get tenting of the skin, you probably have had some of the other signs before. And the only screenshot I could find was from the doctors. I'm not trying to endorse that TV show or not. I don't know anything about it. But it's also a little bit harder in folks who are older. The skin turgor can change, and so some people might find that they have tenting all the time. So it's more kind of a comparison to what your baseline is. And then,
what does that mean, tenting?
What was that? Oh, I'm sorry. So in the picture, so you guys can do it. If you pinch the skin on the back of your hand, in a baby, it kind of springs right back. And then in me, it kind of springs right back. And in older people, it might take a little bit longer to spring back. Okay, so tenting is when it stays up for a longer period of time than it normally would. So it kind of looks like there's a tent on the back of your hand. Fevers. What's the number that is an emergency?
105.
What was that? 104? There
We have
is no
7.
number. There's absolutely no number. From our perspective, there's no number at which we say, oh, geez, this is a problem. So a temperature of 100.5 or over is considered a fever. And I don't think I've seen very many 106s, but they happen. And any fever is a fever. So 104.1, all right, you have a fever of 104.1. That doesn't tell us as doctors what is going on. It doesn't tell us that you're sicker or less sick than somebody who has a fever of 102.5 or 101.1 or whatever. So there's not a specific number. Okay. Ready?
Yes. So we'll talk a little bit about, move on to chest pain. So the goals of this, it's good to have goals. So when should I see the doctor? Go to the emergency room for chest pain. And our next goal for this section is, what can I do to help prevent a heart attack? And the last goal is, what do I do if someone is having a heart attack? So hopefully we'll be able to communicate something about all these. I do just want to say at the outset, though, the first goal, I'm not going to be able to give you, unfortunately. I hopefully will be able to give you some information to help you make the decision, but it's a really tricky thing to know. Chest pain is a really common symptom, but we'll give you some background information about it and hopefully make you more informed so you can make more informed choices for you. So this case, a 45-year-old malpractice attorney has 3 hours of chest pressure that radiates to his jaw. It's associated with shortness of breath, sweatiness, and nausea. He's never had this before. He's worried because both his father and his grandfather died of a heart attack before they were 50. So any question about what this is for the sake of this case? So this is a heart attack, right? This is the textbook classic heart attack. So you have a discomfort in your chest. Sometimes it's an ache, sometimes it's a pressure, sometimes it's burning. It radiates to your jaw, to your shoulders, to your back, often associated with shortness of breath and sweatiness and nausea. And everyone should have that picture of the classic heart attack in their brain. If you have those symptoms, that is certainly a reason to go to the hospital, the emergency department. The treatment for heart attacks takes place in a hospital in the cath lab most commonly. The longer your heart doesn't have blood, the more heart muscle dies and the worse your outcome is. So this is a very time sensitive. Yes, ma'am.
So this is a man. What is it for a woman?
Oh, you're a plant. Perfect. So we'll get to that. So that's a classic heart attack. And then the other important thing to know when we're talking about the heart, so that's a classic heart attack, is risk factors. And there's classic risk factors that probably you've talked to your doctor about or read about. Some of them you have control over and some of them you don't. The first two, age, you can't really control, and your family history you can't really control. So if heart attacks run in your family, you're at much higher risk of having a heart attack. Those ages are obviously not cutoffs. There's lots of people below 45 who have heart attacks. There's people in their 30s who have heart attacks. There's people in their 20s who have heart attacks. What's the youngest heart attack anyone the pediatricians have seen? Anyone?
I don't know.
So certainly
I've
20s.
seen like
I don't know that I've seen
it.
what's that?
I've seen a 3-month.
3-month
That was
old, okay.
cool.
So the rest of, so that's younger than 45 years. So the rest of the risk factors are things that actually we all have control over. So tobacco is a really significant risk factor, smoking. So tobacco does a lot of damage to the blood vessels. Your heart is a muscle. That muscle is fed by blood vessels, just like all the muscles in our body. And tobacco damages those arteries that feed the muscle and has a really proponent effect on heart disease. Diabetes, similarly, I think of them, they're certainly different disease processes, but diabetics also have a very pathologic process with their blood vessels, such that they're much more likely to get obstruction of their blood vessels, which leads to heart attacks, strokes, infections in their extremities. Cholesterol is obviously a function of diet and exercise. Hypertension, function of diet and exercise. There's certainly a genetic component, but a lot of it we have control over. Obesity, exercise, and stress. So smoking's a big one. Exercise is another really big one, and diet. And the benefits of exercise as well as diet go far beyond heart disease. There's benefit related to stroke and cancer and general health, and movement the same way, especially as we age. Muscular strength in terms of being resistant to injury, falls, better balance, all the accessory benefit you get from exercise is just increasingly important as we age. So, okay, so we heard about a classic case of heart attack. That's easy. Most of us know risk factors. And then we've got this piece of information, which is that in my field, most malpractice dollars are paid for missed heart attacks. So that's not perfect. And then we got this other piece of information, which is that there are about 6 million visits to emergency departments for chest pain. About half of those people end up staying in the hospital. So the doctor has enough concern that they put about half of those people in the hospital. And yet, of that half, that 3 million, only about 15 to 30% actually have a problem with their heart. So on the one side, we, doctors, miss people sometimes, and we also put a lot of people in the hospital who don't have heart disease. So this gets to some of the point of why it's really hard to tell you all when can I really know that you need to go to the hospital versus don't need to go to the hospital. Because even after we see you and talk to you and examine you and get an EKG and an X-ray and blood work, we don't get it right 100% of the time. So why is that? And there's a couple reasons. So this is a little graph of the body, and the point here is that there's a lot of stuff packed into the middle of our body, right? There's your windpipe and your esophagus and your lungs and your heart, and there's your liver, and that little green thing is your gallbladder. Maybe some of you had your gallbladder out. There's your stomach, there's your intestines. And the other thing about the inside, so on the outside of your body, if I walked around, or if I walked around and touched everyone's finger somewhere, right, you would all have about the same sensation. You would all know, oh, you just kind of hit my finger, my index finger, the tip of my index finger with your finger. But on the inside of the body, the wiring is much different. So it's just much less precise. So your appendix may be rupturing down here, and you may have pain up here. And the same with the heart. The problem in your heart is here, but that doesn't mean you're going to feel it here. And as we get to the next slide, which gets to the first question we had, is what we talk about with the heart is that the typical heart attack is actually atypical. So that story of that person, yes, it's very classic, but it's very, 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 very rare. And so what might a heart attack be? Well, the pain, one thing we often talk about is pain, but a lot of people who have heart attacks wouldn't use the word pain. It's often not that severe that they would say that's a pain. It might be a discomfort. It might be a feeling. Instead of pressure, it might be sharp or stabbing. It might actually be reproducible. You might think that maybe I did too much yard work. Maybe it was from fishing. May feel like heartburn. You may not have any pain at all. You may just feel weak. You may just feel like you have the flu. You may just feel like you're nauseated. And the last line seems like it's cheating, but you may not actually have any symptoms at all. So where does that leave you? Little sidebar. Has anyone seen blood work? Was it good? So as I was Googling blood work, I wanted to get a picture of blood work, which I didn't end up including. I came across this and then went to Rotten Tomatoes, and the description of this was a competent thriller with a lethargic pace. And it reminded me of working in the emergency department, or just being in the emergency department, a competent thriller with a lethargic pace. So, but on behalf of all emergency departments that you've been to and the work we do recognize that we sometimes do have a lethargic pace as we're trying to manage multiple competing priorities. And we do try very hard to be competent, although like everyone, we're not perfect. So what can you do? So you can know the classic symptoms. Certainly if you have the classic symptoms, that's a reason to go to the emergency department, to go be seen, to get medical care right away. Symptoms with exertion are another red flag. Symptoms that come and go in some manner, some waxing and waning manner. You also need to know that heart symptoms, most of them are not classic. And so you just need to wait for the last point. So also your risk factors. So risk factors increase your risk of a heart attack. So know them, but even more importantly, I would encourage you all to help to manage them. And that's a combination of diet, exercise, quitting smoking, and then managing, if you have diabetes or hypertension, managing that as best you can with a combination of medicines and diet and exercise. And then, unfortunately, it feels a little bit like a cop-out to say this, but you just need to use your judgment. And there's lots of discomfort that people get in different part of their bodies. But anytime that I see anyone in the emergency department and they have any sort of symptom between their hip and their heads, I'm wondering, is this their heart? Could there be their heart? It's unrealistic to say you should go to the emergency department anytime you feel anything between your hips and your head. But I think the take-home point is use your judgment. Don't rely on severity of symptoms. Often the symptoms can be mild, and if it feels not right, I would just encourage you to use your judgment and access health care. So for a heart attack, a couple quick items. Aspirin is an amazingly effective therapy. In my job in the emergency department, it's one of the most effective treatments we have. If we give it to about 45 people, you end up saving one life if they're having a heart attack. There is essentially no downside unless you're allergic to aspirin. So if you think you are having a heart attack, you should definitely take an aspirin, chew it as early as possible. It is in studies that were shown when it was studied against giving the clot busters, which were sort of out and about before. Sorry? One aspirin, adult aspirin, 325. When it was studied against the clot busters, which sort of came out before the fancy stuff they do in the cath lab, it was equally as effective as that high-tech medication. And then we'll talk a little bit about CPR and AEDs in a minute. So I wanted to just go for a couple minutes about, talk a little bit about obesity as sort of a compilation of several of the risk factors. You know, obesity has an exercise component, it has a nutritional component, it has a lifestyle component, it has a diabetic component, it has a hypertension component. So obesity by definition is a BMI greater than 30. And just for point of comparison, if you're 5 feet and 155 pounds, that puts you as obese if you're 6 feet and over 225. And so this just looks a little bit at numbers of what's happened in our country. So in 1990, there were 10 states that had a prevalence of obesity of less than 10%. And in 2010, no state had a prevalence of obesity less than 20%. In 1990, no state had a prevalence greater than 15%, and in 2010, 36 states had a prevalence of over 25%. And then that top bar talks about the pediatric population. So nationwide, the pediatric obesity rate is 17%. And in emergency departments, it was found to be 46% in a study, which just drives home the point that that obesity has significant effects on your health and makes it more likely that you're going to require care in the emergency department. A lot of this is a function of, again, what I mentioned, the affluence of our country. As countries become more affluent, the opportunity for food increases, and the opportunity for labor that requires physical movement tends to go down. I'm sure there's other factors, but you can see that, that other developing countries are headed in our direction. So this just gives a couple pictures of the kind of the same point. So this has the BMI is on the bottom, and remember 30 indicates obesity. And on the y-axis is the prevalence of diabetes in this. So you can see that as you get above, I mean in that female slide, it's incredible. Once you get to a BMI of 35, the incidence of diabetes is in the 90% range. So a little bit of a male-female difference. And this shows the effect of obesity on death from a cardiovascular event. Again, once you get into that obese line, you can see the graph shoot up. The y-axis is the risk of death from a cardiac event. And this is cancer, showing the incidence of cancer related to obesity. Again, you see the steep slope once you get above that, the second mark, which is the 29.9. And we will skip that one and go to CPR. So how many people, so now we're at the other end of a heart attack, which is sudden cardiac death, we call it. That's the people who are doing something and then they end up on the ground. So how many people know CPR? Wow. How many people feel comfortable doing CPR? Good. Does anyone want to, who does not feel comfortable? How many people do not feel comfortable doing CPR, or do not know CPR? Okay, so a handful. So we're going to do, so CPR is fantastic for lots of reasons. The data on that is if a person has bystander CPR, they're twice as likely to survive. So that is pretty remarkable. I don't increase people's mortality by ×2 in the work that I do. So it is a remarkable opportunity to save someone's life. You'll also learn how to use an AED. AEDs are everywhere, and it's another fantastic, by applying electricity to someone's heart, you can take them from dead to awake and talking to you. We are going to have maybe, so there are, the CPR classes are great, but even if you're not instructed in CPR, there are some books back there. The American Heart Association puts out books for people who are not actually CPR trained because it is really, really easy. And so we're going to simplify it for you for those people who aren't currently certified. And the recommendations are to try to wake the person up and watch them for 5 to 10 seconds to see if they're breathing. And if they're not breathing, to do chest compressions at 100 to 120 times per minute. And that's it. And we have I think we have a volunteer in the audience, I heard. Yes, he's coming down right now, and he's going to show us.
Wait for somebody else to come.
He was going to show us the simplified yet very effective version of CPR if you haven't been trained.
Do you want me to use the table or?
Can people see on the floor? No. Yes, we'll use the table.
I just pick them up, throw them over my shoulder like this, no problem. So, yeah, I mean, I think the main thing to know is that if somebody does not have a pulse, they're dead, right? So, if you don't feel comfortable about doing compressions or being part of this, it's important that you are, because anything you do is beneficial. They're dead until you do something. So the only two things that will prolong their life or that will bring them back to life are A, chest compressions, and B, a shock if that's appropriate. So you find their sternum. Everybody knows where their sternum is, right? Good. The xiphoid process, a little bone right here. And you go up about 2 to 3 finger widths from that.
From the bottom,
From the bottom of the xiphoid. Yep. Xiphoid process right here. So go up 2 to 3 finger widths. So put your fingers right here and go up 2 to 3 finger widths, and that's where you set the edge of your hand. So here's their xiphoid. So I'm going to go up 2 to 3 finger widths, and I'm going to put my hand right over that spot. Then I'm going to lock my hands like this. It's important to keep, don't try to use your arms because you'll get tired. And so it's important to lock your arms and let your body weight do it. And like Mark was saying, 100 to 120 times a minute, that's fast.
They say the sound of staying alive.
Yep, that's really fast, right? Are we ready?
So does anyone have a stopwatch? So someone start them and let us know in 15 seconds. So,
I'll sing it if you want.
okay, we'll do it. Who's going to count? You want to count?
Oh,
Ready?
yeah, I'll count.
Go. Stop.
That was 120.
So essentially, you have to really push hard and you have to really go fast. And I think don't be afraid to do this because you are saving somebody's life if you do it. So
absolutely will not hurt anyone.
You don't have to be an expert. There's not a lot of other algorithms to this. Just do the best you can and push on their chest. And we can practice afterwards if you want.
Yes, sir.
Which part of your hand did you put on the spot?
The palm. Yeah.
Right.
So, yeah.
Heel.
Yeah. The heel of my hand. Exactly. Yeah.
When a person with a heart attack arrives in your emergency room, you don't do CPR, you start using a chemical or something else. What is it you in fact do or try to do?
So there are basically, I didn't go into this, but there are basically 2 types of heart attacks where the phrase is used. The top one is the heart attack we were talking about where you have chest pain. So that's a picture of the heart. Those are arteries in the heart. When you get a blockage there, you get symptoms or you don't get symptoms, as we were talking about. But you get pain and heart muscle is dying, and we give you aspirin, and we get you to the cath lab or give you a clot buster. So that is that type of heart attack. The heart is powered by electricity. So you've got these pacemaker cells. They tell the heart to beat. And depending on your pulse rate, if your pulse rate is 60, that's because you got these little cells in there that are saying beat, 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 beat. When you're having a heart attack, so that's what this big line is, beat, beat, beat. Sometimes when you're having a heart attack, the cells say, we're not listening to you anymore. We're just going to do our own thing, and we're all going to beat whenever we want. We're just going to do our own thing. And then you just get this, instead of this muscular contraction of the heart, you just get this quivering, which doesn't push blood through the system. And so that's, in that setting, when the heart does that, the heart starts quivering. About 5 seconds after that happens, the person goes unconscious. That is when you start CPR. And the goal is to apply electricity, either from the paramedics who have their manual or an AED. And you just are basically whacking the heart and saying, you guys all start beating together now.
And I think-
and it's a remarkably effective treatment for that.
And we do CPR in the hospital. I mean, I don't know
Yes.
how, like, we do it. It's just a matter of if you walk in having a heart attack and you're talking and you say, I have chest pain, CPR, you would be very upset at us if we gave you CPR. But if you don't have a pulse, then that's the situation where Dr. Simon would be doing chest compressions in the ER. So.
What if there's a inverted sternum, there's a hole in their chest? Push on the side or what?
Nope. So if their chest sort of is caved in, you would still just do the same thing.
Okay.
They are dead.
Yep.
They don't have a pulse, they're dead. So unless you do something, don't worry about what you do, just do it. Seriously, yeah.
Push hard, push fast, and 100 to 120 is the number.
What is the normal heart rate? 80, 75?
80 is probably the textbook answer, but everyone has their own normal. So some people will be in the 40s, some people will be in the 50s, 60s, 70s, 80s, 90s. Most people are below 100, but some people are above 100. And there's little people who have different heart rates,
Yeah, they can go up
depending
to
on age.
180 I'm okay with in a little tiny kid. A lot higher than that, you get a little concerned. Is it my turn?
It's almost 15 minutes, I think so.
Okay, we're totally gonna switch gears. You guys can still ask questions about CPR, but I'm gonna take a second and talk about head injuries really quickly. So does anybody know who this is? I hope it's Mike Tyson. That's who I was hoping to put up there. Okay. So this is another made up case, but you have a 19-year-old son who has just started his collegiate boxing career. I don't know if there are colleges who have Division I boxing, but let's say there are. And he calls me on the phone and says, man, I'm having some trouble concentrating in my classes. I've been getting some headaches, and I've had a bunch of these really rough, I think they're called matches, and I've been hit in the head a bunch, but I think I'm going to do okay. So just from that phone call, is that an emergency? I heard it could be. I heard some yeses. Yeah, worth checking. Okay, good. What do you think? Does anybody know what's going on? Yeah, so concussion is probably what's going on. So concussion has been in the news a lot over the last few years. We see it a lot in pediatrics because there's pee-wee football and there's all sorts of other ways that kids hit their heads. But it also happens in adults quite frequently. There is a lot of emerging research about the severity, how important it is to recognize a concussion early, and to be, we call it removed from play, but it's removed from whatever it is that made you hit your head in the first place. So oftentimes we talk about concussions in athletes, but you don't have to be an athlete to get a concussion. If you fall down the stairs, if you're in a car accident, if you're a totally non-athletic person and you hit your head and you have concussion type symptoms, that's still a concussion. You don't have to be an elite athlete to get a concussion. Second impact syndrome, has anybody heard about that? So basically so say you get a concussion, and I'll talk a little bit about what concussion symptoms are. They're very vague, kind of like chest pain symptoms. But if you get a concussion initially, and then you get a second concussion at some later date, the ramifications of that can be really severe. So that's when we see problems with, I don't know if you guys have seen in the news, every now and then something pops up like a teenage football player dies on the field from a head injury or something like that. That can often be due to something like a second impact syndrome. And it's because of that second injury, the brain hasn't finished healing, and then you have that second injury that can do some really severe damage. What are concussion symptoms? Confusion? Headache?
Eyes not being the same dilated.
Okay, so eyes being different sizes. So sometimes eyes being different sizes is usually a more alarming sign than just a concussion. Any other things? Yeah, sleepiness, yep. Emotional lability, so feeling like you don't have control over your emotions. Having trouble concentrating. Some people don't have very many symptoms at all. Sometimes people feel like they're just a little bit clumsy. So they're very vague. Do you have to lose consciousness to have a concussion? No. So if there's ever if there's a question, if somebody says, hey, I wonder if you got a concussion, don't mess around with it. Don't say, oh, I'll just go back to, I don't know, riding the horse or whatever it was that you were doing that made you hit your head in the first place. You need to be evaluated. So the question of whether you need to be evaluated in the emergency room versus whether you need to be evaluated by a provider soon, again, is one of those use your judgment questions. So there are a couple of red flags that I would say absolutely you need to go to the ER. So those are in the red box. So any kind of neurological disturbances. So the pupillary, the change in your pupil dilation, so if one pupil is very small and one pupil is very big, that's concerning and should be evaluated right away. Anything like slurred speech, not using half your body, the kind of the obvious neurological signs that something is just totally not right about that person would be a big problem. Loss of consciousness that persists. Some people faint, and that isn't necessarily an emergent thing. But if there's a true loss of consciousness, it's something to worry about and to think about getting evaluated quickly. And persistent vomiting, so over and over and over, not being able to keep anything down. And those are just a few red flags. There are all sorts of red flags. And does anybody know what somebody's head CT would look like if you got a head CT in the ER with a concussion? It would look like that, which is totally normal. So a concussion, there are no signs on your head CT. So oftentimes if you go to the ER and you get evaluated, or you go to a doctor and get evaluated, most of the time, if we truly think you have a concussion, we probably won't get a head CT, the kind of series of x-rays of your head, because it's excess radiation and we don't want to expose you to that kind of risk if we're pretty sure it's a concussion. That is in comparison to that, which I don't think you have to be a doctor to see. There's something wrong with that. There's something different with that, right? So the lighter part is blood in the brain, and that is a sign that there's something more serious going on than a concussion, and that's when you see, like, you can see a blown pupil with that. You can see some pretty severe neurological disturbances with that. This isn't really emergency room talk, but I wanted to just bring home the importance of how serious a concussion can be, because a lot of us will, I don't know, growing up, we would walk around and you'd have a collision on the soccer field and say, oh, maybe I got a concussion. You just go back onto the soccer field. But we're pretty serious about it. So we usually advise complete physical and cognitive rest. So that's often really hard for people, and that means you don't go for a run. You don't get on the elliptical. You don't do your soccer training or whatever it is. You don't get on your bike. But you don't do homework. You don't do reading. You don't watch TV. You don't do anything. Complete rest until your symptoms are gone. And there's a very gradual return to play kind of schedule that you can do, and there are repeated assessments throughout that return to play. And that's to help avoid problems with the second impact syndrome. There is a little bit of data that's starting to come out that we might be able to speed that up a little bit, but I won't confuse anybody with that. We don't even know exactly how that's going to manifest going into the future. So. Okay.
What's the relationship between concussion and subdural hematoma?
Good question. So they're two totally different things. You can have a concussion and a subdural hematoma. A subdural hematoma is that picture. And a subdural hematoma means there's blood in the subdural space. So the dura is what is part of the lining of the brain. It means there are some blood vessels that were sheared or that had some injury, and so it let blood into that space around your brain. And it can cause compression of the brain tissue. A concussion is it's injury without necessarily bleeding of the brain tissue. So it's kind of like a bruise without bleeding of the brain tissue. So they're very different things. You can have both. Usually when you have both, the more serious one, the thing that we get more worried about would be that subdural hematoma. But, okay. Moving on.
So time is shortish. So wounds, or, and maybe we'll get to both of them, but wounds or opiates? Wounds or substance abuse? Wounds. Perfect, that's right where we're at. So, so the goal for this, hopefully make you a little more comfortable taking care of your own wounds, to make you a little more confident, again, when do I access healthcare for wounds? And 3, a lot of people around here like to be away from town and out on their own, and hopefully if you encounter an injury, a wound, make you more comfortable in caring for it in a way that actually decreases the risk of infection, improves healing, etc. So when I think of wounds, I think about 3 things. 1 is bleeding, 2 is infection, and 3 is this closure versus protecting the tissue. I think of closure, when I think of closure, I think of it as not necessarily bringing the sides together, but basically a way to protect the tissue underneath. And for the sake of argument or the discussion today, let's think of it that way, because really at the end of the day, that's what you want to do. You want to protect the tissue underneath. So bleeding, how do you stop bleeding? So clearly the most effective way to stop bleeding is with your hand, directly, direct pressure, 15 minutes at a time. So 50, not looking at it every time. If there is a lot of blood, then it's important not to just bury all the bleeding in a bunch of tissue and gauze and shirts. You want to actually see where it's bleeding, because if you just cover it up and apply some vague pressure, you may not actually stop the bleeding, you just might not be seeing it anymore. And so what you really want to do is, as best you can, identify the place that's bleeding. Up above there is a tourniquet. So tourniquets are widely available now. They're inexpensive. I think that's $25. They're small. They are incredibly effective, but at the same time, you don't have to have a tourniquet. There's lots of ways to, you could do the same thing with a towel or a tent or a sleeping bag. All you need is a little material, and basically you're just going to keep twisting it until you twist it tight enough that the bleeding stops. And tourniquets used to be feared because we thought that we would be doing so much damage to people's limbs if we put it on for a short period of time. One of the unfortunate or fortunate outcomes of the unfortunate wars that have happened of late is a lot of experience with tourniquets, and they've been used very effectively in the military to save a lot of lives. So if someone is bleeding and you can't get it stopped from an extremity, a tourniquet is a very cheap and effective way to save a life. So then comes infection prevention, and this follows the saying, the solution to pollution is dilution. You don't have to have a fancy hospital thing. You can use a plastic bag and just cut the corner out and fill it with water and apply some pressure. You can use a Camelback, same thing. You've got a bag and you're just trying to irrigate. The purpose of this can is so people often want to know an amount. How much should I irrigate? How much is clean? And there's really not a right answer. You just want it clean. But an answer that's given is 50 to 100 milliliters per centimeter, which is like what? What is that? So fortunately, a can is perfectly apportioned. If you take the diameter of the top of a can, if a laceration is exactly that long, then you would use the volume of the can, which is 355 milliliters. So it gives you a little bit, if it's about half the size of a can, a laceration, then you'd use about half the amount of liquid that's typically in a can of soda or water or anything like that. So it just gives you a little bit of a visual of how much. So risk factors for infection, and the 2 sides of the teeter-totter are risk of infection, closure of the wound. So a wound that's at higher risk of infection, you're going to be less likely to close. Because when you close a wound, you actually increase the risk of infection, because those little bugs like that deep, dark, moist place. When it's open and exposed to air, the body has is better capable of fighting off the infection. So how dirty is the wound? Is it a puncture, right? There's no air getting there when you just have a puncture. Is it a bite? So human mouths, dogs' mouths, cats' mouths, they're very dirty, and there's often, again, a puncture component from teeth. Is there a lot of damage to tissue? So if you have a lot of damage to tissue, it affects the blood supply, and the blood supply is sort of the infection-fighting army. And if you disrupt that, it's going to be more prone to infection. Location, so location, generally as you get further away from the center of the body, things are more likely to get infected. The feet are notorious for getting infected. The face is notoriously resistant to getting infected because there's lots and lots of blood flow, which is why it bleeds so much when you get a little something. And then the underlying health of the person. So closure and tissue protection. So let's see. So up at the top left is that's a puncture wound, right? That's a nail. No one's going to close that. That you want to clean out. People talk about prophylactic antibiotics to prevent infection. Different doctors have different approaches. You'll probably get 7 different answers if you talk to 7 different doctors. The more likely it is on the foot, which is really prone to infection, the more some are likely to give prophylactic antibiotics. But certainly you're never going to close anything like that. The picture on the top right, it's a little hard to see. That's a dog bite. And I don't know if you can make out the bruising. There was quite a bit of bruising on that, which increases the risk of infection. And so the way we close things, there's a couple ways to close things. There's steri strips, which most people know about, little pieces of tape that you can buy and use to cross a wound. There's a stapler, there's suturing, and then there's crazy glue, which is very practical for those. I know I use them a lot just on my hands at work. If you get a little nick or something like that, you can just put a little crazy glue in it, and if you're washing, or on it, and if you're washing your hands a lot, it just keeps everything tight. So it's a nice little trick. But again, I think a lot of times a lot of focus is on closure. And let's just look at the hand in the middle. So can you make that out? There's a pretty big wound there. So who knows how to take care of that if they're out in the woods and in the backcountry? So antiseptic. So we'll stop the bleeding, we're going to clean it, and then we got to do something with it. So antiseptic has sort of fallen out of favor for actually putting in wounds. It is betadine is a big one that people knew that used to use, but it actually is tissue toxic and damages tissue and is thought to maybe not be the greatest thing. So we're not going to close that, right? I mean, if you're out in the woods and you've never sutured before, and even if you have sutured before, no one's going to close that in the woods. So how could you protect it? Because again, if we're not going to close it, we got to find some way to protect it. Green leaves. Green leaves? And basically what we're trying to do is replace the function of the skin. So the skin keeps all the moist stuff in. So generally what we do is you need a barrier because our skin is waterproof, right? But if you just leave this open, all that tissue that's important that you want to use when you get back to town and the doctor fixes it, you want to allow it to maintain its moisture, its integrity. So we would put, if you had antibiotic ointment, you just smear it with antibiotic ointment. If you didn't, you just get something clean and get it wet with water. And you would put it right on top, and then you'd cover it with something dry and protect it. And then you'd change that 2 times a day or something like that. And that not only is good for the backcountry, but that's actually what we do with really complicated wounds, even if it happens here. So if you have a really, really dirty wound, a really big defect, what doctors will do, they won't try to fix it. They'll just wash it out, get it as clean as you can, and then put some wet stuff on it, cover it with some dry stuff so that you kind of maintain that waterproof barrier so things stay moist, and you let the body do its thing. It's sort of fighting the bacteria, and then you wait a couple days, and then they'll go to the operating room and get it fixed. So the point of saying all of that is that any wound you have anywhere is never an emergency to get it closed, ever. It is an emergency to stop the bleeding. You definitely want to clean it out as best you can. And you want to protect the tissue as best you can by keeping it moist, keeping it covered, keeping it clean. But there's never an emergency to get something closed. They can always be closed at a later date. And scars can be revised and things like that. The main, the child on the left there, that child was actually not sutured. So the decision was made that laceration was, whenever we, especially in kids, we're always thinking, because it's a bit traumatic, either holding them or giving them medication, which has its own risks. So that one was not treated at all. This one is a significant laceration. Most people would want that sutured, but at the same time, if you were somewhere out in the woods or if for financial reasons or whatever, that would heal. The main reason to suture wounds like that is cosmetic, right? It makes a smaller scar, and it's a lot easier to care for. Because if you don't suture that, you're probably going to be getting your pillow bloody for maybe a week, and you're probably going to have a scab there for maybe 2 or 3 weeks. Whereas if you just bring it back together, the healing can happen quickly. So, bacitracin. So in terms of antibiotic ointment, just small point, there are people who are allergic to neosporin, neomycin. So bacitracin, I don't know that, there's probably someone that's allergic, but it's got a much smaller incidence.
I think, so we could talk about pediatric ingestions and poisonings and stuff like that. Or we can take a little bit of time to answer questions. We only have 5 minutes left, so I want to get a feel from you guys.
We never did address the female heart attacks.
Shoot. So they would have a higher incidence of being different. And that's what I would say, that again, symptoms men and women can have atypical symptoms, can have no symptoms. And there are, women often have atypical symptoms, diabetics often have atypical symptoms. So classic is out there, but there is a lot of not classic heart attacks. And it can come in lots of shapes and sizes of something. You know, the things that, the classes of symptoms that you can have are a feeling. So there's a sensation. Let's put it on the pain spectrum, right? So maybe it's burning, maybe it's stinging, maybe it's aching, maybe it's sharp, maybe it's stabbing. So there's that whole spectrum. There's a sweatiness component. And sweatiness in general in my field is always concerning. It's basically your body saying that it's doing everything it can to keep doing what it's doing. And if you're not doing anything, that means it's doing everything it can to stay alive. There's a sort of nausea, vomiting realm of symptoms. And then there's a sort of general fatigue, weakness, malaise. I feel like I have the flu. I feel something. I feel globally weak. And certainly it's known that women are more likely to have less classic symptoms, but everyone, I don't know that I can give you the answer you want, which is what specifically am I going to have? You may have what you may have, and it's really hard to know and to give you what you really want to know, which is why I said at the beginning that first point would be really hard to give you the important piece. I think, again, things to keep in mind are as those symptoms, as you have multiple of those symptoms, as you have symptoms that are related to exertion, sweatiness, again, is a pretty significant one, but it's just something we unfortunately don't know as much about as we, or can't, the body just interprets in lots of different ways. Yes, sir?
Tingling of the arms, a symptom?
Yes. Tingling is most definitely. Tingling of the arms, tingling of the chest, tingling of the jaw, tingling of the back, yes. And there's lots of overlap as we did with other illnesses that can cause similar symptoms, which makes it really tricky. Yes, sir?
I've noticed that they don't talk about breathing with CPR over the last several years. Is that for clinical reasons, or is it just worried about transmission of disease and other things?
So
are you better off to breathe for someone? Have they got a better chance of survival?
So it's believed that there still is some benefit, although there is some debate. In what we have in those books is a non-CPR class. So the point of this, by far and away, the most important thing is chest compressions. Breathing probably does have some benefit. But for people who are not taking a class, because these books and there you can do a 45-minute or an hour video, is to keep it simple, because as you complicate it, you increase the likelihood that people say, I don't want to do it wrong. I don't want to injure this person. And if you keep it simple, the KISS principle, that people are more likely to actually do what's important, and you're going to get by far and away the bang for the buck for CPR.
In kids, the most common cause of losing a pulse is a respiratory cause, and so even so, the books will say just do compressions, but it's something to think about if you were to come upon a kid who didn't have a pulse. The breathing component is a little bit more important, but again, don't leave out the chest compressions, but it's just something to think about. You know, could they have choked on something or something like that? So.
If you're not certified in CPR, have you covered any of the good Samaritan Act in Alaska?
Should be. Yes. Yes.
You are?
Yes, you are. Yeah, any person can do CPR, and it's I mean, when it's litigated, if it comes to court, if your intentions were to help somebody, just whether you're a doctor or you're a layperson, you're protected.
A big concern, I think, a lot of college, post-college age has is we're like switching from our parents' medical insurance to like off that is cost of going to the emergency room. And so like obviously there's not gonna be a straight answer, but like is there like something that people are coming to this might not be a fair question. Can you name one thing that going to the emergency room for people do too much and one thing people don't do enough? Like one reason to go to the emergency room that people don't go there enough and they should go there more to save lives. And maybe like one that's like people overdo. Again, unfair question.
Yeah, that's a really hard question. I would say there is probably some, what I would say we see more of would be heart disease, where sometimes people, and it happens occasionally, where they tell you a story and you think, wow, you've been dealing with that, who don't have who may have a fairly typical story of heart disease that may stay home. In order to, healthcare is imperfect, right? I mean, as demonstrated by how many people we put in the hospital, and we still miss some people. So in order to have a safe system, you have to sort of tolerate some imperfection in it, right? To make sure. So I don't think there are, I don't know that I would say there are things that people shouldn't go to the emergency room for. It's a very personal decision. People tolerate crisis in different ways and manage crisis in different ways. And although emergency departments are expensive, and I'm not discounting that, there is also it's the only place you can go regardless of your ability to pay. So you are going to get a bill at the end of it, which someone may or may not pay, but you don't have to pay it up front. And people will see you regardless of whether you were there 10 minutes ago and came back for the same reason and then came back 10 minutes later and 10 minutes later. So there's a federal law that mandates that arose in the 70s, I think, from some less than perfect behavior on the part of doctors and shipping people to county hospitals that had injuries that shouldn't have been shipped. So. But I think, I don't know, again, one of the take-home points we hoped to give is that there are no simple answers, but to try to convey information that allows you to feel a little bit more comfortable and to empower yourself to know you're not going to get it right? So. But your health is the most important thing, and so whether you come to the emergency room or go to the doctor and it ended up not being something, again, it's a bit of, you're not going to get it right every time. And so I think you just need to trust the fact that you're concerned about something and that's enough, and that it's time to go talk to someone about it, whether it's the emergency room or an urgent care clinic or your doctor, whether you call them or whether you go see them. Yes?
How long should you perform CPR before you quit? Is there a length of time that you could expect something positive or negative? And how long can one person do that?
Yeah, that's the answer. I think you do it as long as you can. So it's two. People have survived. Again, it depends on the what other factors are happening. Every case, every individual is different. But there's no easy, fast rule to say when it's okay to stop. So you do it until you can't do it anymore. Hopefully, you are somewhere where there's resources. So if you were out somewhere, I would say it's probably not going to work anyway. I hate to be the bearer of bad news, right? But if you're out somewhere where there's no opportunity, because the CPR is you're bridging to something. CPR in of itself is not going to revive people. You're bridging to something else. But there are stories of people getting it for over an hour, 2 hours, and having good outcomes. Often those have some younger person with some environmental component. Often there's a hypothermia component. But there are good outcomes of people getting it for periods of time that seem incredible.
And if you're starting CPR, if you can't, you should call EMS, and by the time continue CPR until the ambulance gets there, and then they can take over. So I know there will be cases when if you're out in the middle of nowhere and you can't call an ambulance, then that's one case. But if you feel like you need to start CPR, then send somebody to call 911.
And there's been huge attention devoted even in the hospital setting to minimizing those stops in time where you're doing either checking for a pulse or breathing, because every time you stop, the blood flow stops, and to get it ramped back up again takes time. And so there's a lot of attention paid to really minimizing those breaks and just having the compressions go, because it's what works.
So I think we're out of time. We've exceeded our time here. We'll stick around and we can answer questions, or you guys can play with the mannequins or the YAM. I don't know what the YAM is for still.
The YAM. Well, there's so there is some wound stuff up there if anyone wanted to see. There's some dressing stuff. There's a stapler. There's some a couple staplers. There's some different wrappings. There's a tourniquet. There's CPR opportunity. So.
Thank you.
Thanks, guys.
You're welcome.